Yeah, so I hope you guys can hear me on Zoom as well. Check. Hi, everybody. Okay. Right. So the first thing I want to get an idea of, because I've got the two students in front of me, how much do you all know about ECGs? Yeah, it's quite some time ago. I'm guessing. No, don't worry. ECGs are one of those things in medicine that just see some. Oh, thank you, Shita. Okay. So ECGs, just because we're starting off the new year, and I want to welcome all those who've been with us before. In fact, what I'm doing, I'm actually using an ECG from last year. It's from February last year, just to kind of get those who are on the group before a little bit into the groove again. And not to tax your brains too much, okay? I just want to reintroduce some of the older people to ECGs. When I say older, I don't mean like age-wise, I mean who've been on the group longer, and like you guys who are new and have joined us. ECGs are difficult for two reasons. Number one, we make them difficult. And number two, we tend to overthink it when we are looking at ECGs. ECGs just need to be broken down into little pockets, and it actually becomes a lot easier, right? And the sad part about ECGs is that you can tell a lot, you can miss a lot, and if you find everything, you can save your patient. If you miss little things, you can kill your patient, And it's the type of thing that takes years to practice. Even I look at an ECG after all these years and I go like, what's going on here, But most of the things do come after a while. So what we're going to do today is we're going to look at a diagnosis that actually is relatively common, even in our setting, that a lot of people miss. But I want to actually get you guys just thinking about an ECG before. Now, if you don't know what I'm talking about as I'm going on, that's perfectly fine. Just look away, put your head down, don't answer what I'm asking. I'll know, it's fine, okay? And then we'll take it from there, okay? So there's fundamentals to reading an ECG, okay? In other words, there's a pattern that we use. Now, this is the ECG that we're gonna look at. I'm gonna put it in a bigger format just now, okay? Oh, yeah, come sit, all right? I'm gonna put it in a bigger format just now, all right? So when we analyze the ECG, these are the steps that we take, all right? So the first thing we do is analyze the axis. So do you guys know what the axis is? What do we mean when we say an axis? It's okay. So yeah. No, it's fine, don't stress. So an axis is basically something that everything else rotates around, So the Earth has an axis, the North Pole and the South Pole, and it rotates around it. You have an axis from the top of your head to your toes. So when you turn like that. You don't drop on your shoulder and wiggle yourself around, you know what I mean? So the heart also has not a physical axis, but an electrical axis, So it starts from the top right-hand side and it goes to the bottom left-hand side. In other words, electricity moves in that direction, okay? And if it's moving in that direction, that's good. If it's moving in the opposite direction or towards the left-hand side or the right-hand side, that's bad. Okay, so that's the axis, all right? And the second thing that we do is we analyze the rhythm. So what's a rhythm? That you should know. I shouldn't explain what a rhythm is, all right? A rhythm is a consistent, pace or consistent activity of something, all right? So whether you are listening to music, whether you're tapping your feet, whatever it is, you tend to make rhythms, all right? So your heart also has a rhythm. Do you know what's the rhythm of the heart? We all know it from the time we're in preschool. It's lub-dub, all right? Atrial activity followed by ventricular activity. Okay, and there's a few ways to look at that, all right? So the way that you analyze rhythm, you first look for P waves. Do you know which one is the P wave? Can you remember? Yeah, it's the first little bump, all right? Can't see it here too well. We'll get into that just now. And then, so the P wave is what tells you about atrial activity, right? Whether the atria are functioning well, whether they're not. So that's the first thing we look for. We look for the lub. Is there a lub? Is it a normal lub? Is it an abnormal lub? All right. Then we look at the PR interval. In other words, the time from a P wave to a QRS complex. The QRS complex is the ventricle contracting. So in other words, we look at the time from the lub to the dump. Is it normal? Is it extended? Is it too short? Is it changing? Do you get what I mean? So for example, it's not good to have lub, dump, lub, dump. Lub dub, lub dub, lub dub, lub dub. That's not right. Okay. You should have lub dub, lub dub, lub dub, lub dub. It should be consistent. Okay. Is the QRS narrow or wide? So this is our QRS complex. So we're trying to see, is it a narrow QRS complex or a wide QRS complex? Narrow is good because it means the ventricle is contracting properly. Wide means the electricity is taking a long time to get through the whole ventricle. So in other words, you should have lub dub, not lub dub. You get what I'm saying, all right? So we're trying to stick to the normal rhythm. Does a QRS come after every P? In other words, is it lub dub, not lub dub dub, lub dub? Do you get what I'm trying to say? All right, so that's what we're looking at. And in are those groupings of lub dubs regular as well? So you can have all of that normal, and it's no use having lub dub, lub dub, lub dub, lub dub, lub dub, lub dub, lub dub. Do you get what I mean? So that's rhythm, all right? The rate, so is it fast or is it slow? Because you can have a lub dub, but is it a fast lub dub, or is it lub dub, lub dub? So that's what you're looking at, okay? And then you analyze each zone. When we say zone, the ECG is placed in particular areas, all right? So each part of the ECG, morning, how are you? There was nothing to hand over, so we just kind of started, all right? So I'm just giving our students kind of the basics of ECGs. Then I will trouble Dr. Moses, other doctors, Percy, everybody to try and give me some answers, okay? And then when we say a zone, what we mean is what part of the heart is the ECG looking at, right? So if you guys are like, what did I come for? I don't know half of the stuff. Don't stress about it, okay? Number one, I've got all of this in full, there's full lectures on the group. In other words, what I gave you guys, the Zoom meetings, right? So you just go back to ECG basics, all right? It's 1, 2, 3, and 4. So it covers these 4 things, all right? Number two, if you guys are stuck and it still doesn't make sense and you want another, explanation, I can have a separate session. We can go through each of the basics again, all right? So from here on out, we're going to try and analyze this one. Okay, so this is a 43-year-old man with palpitations. Okay, so Dr. Nkosi, you are sleeping in your bed. It's 2 o'clock in the morning, and they call you and they say there's a guy with palpitations. Even before you see the ECG, what are you thinking already? Yeah, like they call you for somebody with chest pain. They say somebody's bleeding every time they vomit. I mean, patients who's coughing quite badly. So this time they called you and they said, listen, Dr. Nkosi, our great ComServe, we're all interns here and students. Can you please come? We've got a patient with severe palpitations. All right. So you're going to walk in. All right. As you're walking from your car to the emergency department, what's going through your head? Okay, yeah, you can look at them. Very good. Yeah. Very good. Excellent. So you start thinking of all the causes of tachycardia. Agreed. So what are our different? We got, well, AFib is one, right? Atrial fibrillation, atrial flutter, right? And the tachycardia that comes from the atriums as well is called supraventricular tachycardia. Okay. And then you can start thinking of the ventricles. Are you having a ventricular tachycardia? You know, and there's a few things that come up with that, right? So once you examine the patient and you do the ECG, this is what you see, all right? So what's the first thing you do? Besides calling Dr. Moses, Dr. Mohammed, and Dr. Kemraj, what's the first thing that you do? Yeah, I know, because you see this and you go, oh God, what the hell? Yeah. That's why I'm not stressing too much about you guys giving diagnosis. I actually just want to, I was telling them as well, I just wanted to reintroduce them to everything because it's been a little while since we've done all of this. So, you know, we'll go through. So the first thing that we're going to do is we're going to look at the axis. All right, let's try and determine the axis. So it's a long story. I'm not going to get into it too much now, but we look at leads 1 and lead AVF. All right. So basically, if we want a normal axis, we want the 2 of them to be pointing up. Okay. In other words, the 2 of them should have positive QRS complexes, like how this is the positive QRS complex. But what we can see is we've got lead 1 here, and we've got lead AVF there, and lead AVF is actually pointing downwards. All right. So what does upwards and downwards mean? Upwards for a QRS means that electricity is moving towards that lead. All right. And minus means electricity is moving away from it. You've got to think of each lead as a little people, you know, that thing's kind of looking at the heart, you know, from its own point of view. Okay, so each lead can only see electricity from its point of view, and that's it. Just like you guys can only see me from your point of view. You can't tell what the back of my head looks like. All right. So it's the same thing with the lead. It looks at it, but it's looking at electricity. It's not looking at the physical heart. So in this case, lead 1, which actually sits on this side of the heart, it sits on the left-hand side, is seeing electricity coming towards it. All right. And lead AVF, or the lead of the foot, is looking at the heart from the bottom. So it's seeing electricity running in that direction. Okay. So in other words, it's seeing electricity moving away from it. So it's got what we call the left-sided axis. Okay. Like I say, if that doesn't make sense, tell me. We'll go through it again in a separate talk. Okay. Then let's look at the rhythm. So we talked about P waves, QRS complex. Let's cover all of that as well. So what can you tell me about the P waves? Sorry? There's no P waves. Very good. All right. So there's no P waves, and P waves tell us about the atriums. So what's happening to the atrium? Yeah, very good. So it's either not contracting or it's getting lost in everything. Okay, because the atrium is a very small thing compared to the ventricle. So the amount of electricity it produces is much less. The ventricle produces much more. So either it's not working, or the ventricle is working so hard. It's kind of like the two of you shouting at me, but you shouting louder. I can't hear you even though you're shouting. So those are the two possibilities. Okay, but you're right. There is no P wave over here. So we have no way of telling whether we know there's no lub. So we know we can't talk about the distance from lub to dub. We can't talk about that. And we can't talk about dub coming after every lub. All right. We only know that is dub, 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 dub that's happening over here. Okay. That's all that we can see. We can't see anything else. But what about the dubs, the QRS complexes? Are they narrow or wide? They're narrow, so they're functioning quite well. Okay. And are they regular? In fact, they're extremely regular. Okay. Now, the other thing about the ventricle is narrow only when it's receiving its input from above. In other words, your ventricle must get some sort of instruction to function properly. So if you guys remember your anatomy, you have your SA node, AV node, then your branches, and your fibers and all of that goes along. So each of them is dependent on the higher one. The SA node is called the pacemaker cell because it tells everything else how fast to go. Okay. So your AV node is always looking up at your SA node and saying, should I beat? And the SA node says yes, and it beats, and it does it very quickly. Always use a simple example of, let's say, there's a patient who comes in to see you, for example, doctor, and the patient comes in and you do all the investigations. You are the AV node, I'm the SA node, right? If I come and stand next to you and say, listen, this is a pulmonary embolus to A, B, C, and D, I've instructed you, and you will do the work much faster. If you were there on your own, you'd probably reach the same conclusion. It would just take you a little bit longer. That's kind of what happens when the AV node doesn't have the SA node. It's kind of looking for an input, and the input's not coming. So it says, okay, I'm going to beat, and it lets a slow beat go. I know it sounds very silly, but that is actually what's happening. The actual physiology behind is a little bit more complex than that. But if you can imagine that little scenario, this AV node keeps on looking up, it doesn't see anything, then it gives a wide QRS complex. It takes it longer to do its duty. All right. So what this is telling us is that atrium is still there. It's just hidden. It's giving input. That's why the QRS complex is narrow. So the AV node is getting input. It's just that we can't see where that input is here. We just can't see it. All right. And it's, as we said, it's quite regular. All right. So we know we have an abnormal rhythm. Even if you just know you have an abnormal rhythm, that's perfectly fine. How fast is this going? Pretty fast. Okay. Now, these days, all of the ECGs give you printouts. I'm from a time when we had to work it out. So it's going at 150 beats per minute. Basically, you look at the distance between these, how many blocks, and you divide 300 over that amount of blocks. So it's 2 blocks. So 300 over 2 gives you 150. If it was 3 blocks, 300 over 3 gives you 100, and so on and so forth. Okay, so that's how you work it out with the in-betweens in that. So is 150 normal or abnormal? It's a tachycardia. Very good. All right, what is normal? Yeah, that's right. Okay, so we're well above normal, almost double normal. Okay, all right. Now, what I'm going to do, not to confuse you guys in this one, because we need to talk about zones as well. How many of you guys know about the zones of the heart? Okay, so we'll have a separate teaching session just on that. I think I'm going to have one or two just on the ECG basics. All right, you guys are welcome to attend. Maybe from, what's today? Thursday. We can start even tomorrow morning. I'll do one of them just so that you guys we'll have an interactive one. You can always go back and watch the old video in case I'm a bit tired tomorrow and I don't make sense. Maybe I'll make sense. All right, so we'll talk about the zones, but basically the heart has an inferior zone. All right, so you have leads that only look at the bottom. You have the right AVR, all right, which only looks at the right-hand side, okay? These are the limb leads I'm talking about, right? And then you have the lateral leads that are looking at the left side of the heart. Then you have your leads that you're placing on the chest. So those look at the septum, the anterior, and the lateral, all right? So I'll teach you guys about all of that. But in this particular one, it doesn't make much of a difference, all right? So what do we have? We have a tachycardia, all right? And we have a atrium that is functioning and telling the AV node. In other words, we have an atrium that's telling the ventricle to go fast. Agreed? We just can't see where the atrium is, but it is there, all right? So if the atrium is telling the ventricle what to do, does the atrium sit below the ventricle or above the ventricle? Does it sit on top or does it sit below? Where does it sit? It sits above, isn't it? So if it's above and it's telling the ventricle what to do, what type of a tachycardia do you think this is? What would be above the ventricle tachycardia? What do you think you'd call it in medical terms? Very good. Okay, so it's a supraventricular tachycardia. It's coming from above the ventricle, superior supra. All right, supraventricular tachycardia. All right, so that's how you are getting a tachycardia. So how do we know that this is a supraventricular tachycardia? There's a few ways that we can look at it. All right, so every week when we do these, we look at the, no, it's fine, don't stress. I know it's not the best venue and it's difficult to see everything. So every week, whenever we have these, we always make sure that we look at the answer as well. Right? So we've got a supraventricular tachycardia, SVT. The rate was worked out to be 135 because it was just slightly less than 150. And the patient has a right bundle branch block. Right? So the right bundle branch block is this that you see, this M shape in V1 and V2. Okay, we'll talk about right bundle branch blocks one of the days, but it's not important, right? All right. Well, this is a narrow complex. Well, you could say it just depends, right? Without evidence of sinus P waves should prompt immediate consideration of ventricular tachycardia. However, the treating physician was quickly able to obtain previous ECG that demonstrated sinus rhythm and pre-existing right bundle branch. Okay, not too stressed about this because it's involving a right bundle branch block. That's what makes it a bit more complicated. So one of the things with supraventricular tachycardia is they tend to be extremely regular. Now, if you and I measure our hearts, like if we put on an ECG or a pulse monitor, we all have what they call sinus arrhythmia. Because when you breathe in and breathe out, your heart just goes a little bit up. Breath in, your heart beats slightly faster, and then in between breaths, it just goes slightly lower. That's normal. That's how it's supposed to be. So the supraventricular tachycardia is exactly the same. It never changes. So if it's 140, it's 140. If it's 180, it's 180. And if it does change to something, it moves to that and stays at that, you know. So if it's 180, it's 180. Then it goes down to 170, it's 170 again, all right? So there's a few ways that we establish it, all right? Sorry about that. There's a few ways that we manage it, all right? So it depends on whether it's stable or unstable. And the thing that tells us about stability or instability is actually your BP, all right? So if your patient's hypotensive, they're unstable. If they have a decreased level of consciousness, they're unstable. If they are in shock, they are unstable. If they have chest pain, they are unstable, okay? And the thing is, hypotension will lead to the rest of them. So hypotension is your most important indicator, all right? If your patient is stable, then you can try emergency treatments, vagal maneuvers, medications. There's a lot of things that you can use, and I'll show you one of them now, one of the vagal maneuvers. And if your patient is unstable, you need to actually treat them almost immediately, all right? So you've got to do something we call synchronized cardioversion, right? Synchronized defibrillation, right? So how do we treat them? Well, let's say they are stable, right? We establish IV access. We consider giving a drug called adenosine, right? And we can give a second dose. And if adenosine is not effective, we give amiodarone, okay? Now, adenosine, while very effective, is very difficult to give. It's not an easy drug to give. It has to be given very specifically. It has to be, it's basically deactivated by your blood plasma almost immediately as soon as it hits the bloodstream, but you need it to get to the heart. So there's a very specific way that we give it, where we have to protect it with crystalloid solution. So even if you do give it, chances are you won't get it right. Amiodarone, however, we just put in the drip. How many have we given this last year now? Lost count. Yeah, so we see SVTs quite commonly, all right? So the drug that we use here is called amiodarone, okay? And I'll show you guys how we use it just now. And if your patient is unstable, we do synchronized cardioversion or synchronized defibrillation, all right? So in this patient, we would do it at a, at about 50 to 100 joules. There's a whole thing here, but these are all algorithms that are well available, right? You can go through. Right, let's go. So adenosine, right, like we were saying, it's normally given via a three-way tap, but this is difficult. Sometimes you can give it with a crystalloid, in other words, mix it in a syringe and give it, but sometimes that doesn't work as well. So the one we use more commonly is amiodarone. We put 300 milligrams in 200 mils of normal saline, 5% glucose. I think you can put it in fingers as well, but I can't remember right now. And you give it over 10 minutes as a bolus, and that should drop your patient's heart rate quite far down. And then if it has worked, then we give another infusion of 150 milligrams in 200 mils, but we're only running that at 5 to 10 mils per hour, so extremely slow. Considering the first one we gave the entire thing in like, 10 minutes, the next one will be run over, how long will it take you? 40 hours to give you the next 150, all right? So it just shows you how slow it's supposed to be given and how quick we give the bolus to try and drop it down. Overseas, sometimes, especially those of you who go to Canada and UK, they use procainamide. Right? It's another drug that they use, but we use amiodarone in SA. Okay, so we're going to have a look at something that we call vagal maneuvers. All right. So there's a whole lot of vagal maneuvers. Some of them you may know, for example, the carotid, rub. You may know about putting ice packs on the head. Getting the patient to blow out with force, the Valsalva maneuver. There's quite a few of them that you can use. But for SVTs, this is the one that works best, right? And it's called the revert maneuver. So we're just going to watch a quick video about that. Yeah.
I'm Andy Applebaum. I'm the chief investigator for the recurrent study. I'm also a consultant at the Royal. Up in an extra hospital in the southwest of England. Hello there. I see from your heart tracing that you've got a condition called SVT. The REVERT trial was a randomised controlled trial to look at a method of modifying the Valsalva manoeuvre for the treatment of SVT. Asked you just to get a good seal around that with your mouth and blow hard enough to make the needle reach the top. Modification was designed to increase venous return during the relaxation phase of the manoeuvre and involved laying the patient flat and lifting the legs in the air at the end of the strain phase. Overall, we found that patients that were randomised to the standard manoeuvre, only 17% of patients were cardioverted to sinus rhythm, whereas for the modified technique, 43% of patients returned to sinus rhythm.
See how you see your P waves there now? Right, where there were no P waves before.
It really does demonstrate marked improvement with the modified technique. And I think we should consider using that as a standard approach to the initial treatment of this condition. 5, 4, 3, 2, 1, and just completely relax. Lift your legs up in the air. So we used a blood pressure manometer that was modified for the trial, and that can be done in emergency departments, but in other practice or usual practice, a 10mm syringe blown just hard enough to start moving the plunger, we believe gives a similar sort of pressure. So you ready? And ready, steady, blow. And the benefit of that is that patients can use this at home and outside of the hospital because it's a condition that can recur, and that gives the patient some control and may mean that patients don't need to come to hospital in the first place. Okay, and we'll set you back up now.
Okay, got it. That poor guy, I wonder how they kept on getting his heart to go fast.
Go back to normal
I don't know.
so we're just going to repeat
All right,
testing.
so the other thing when it comes to all of these maneuvers, how many of you guys do hard drugs? Like real proper hard drugs? Right? No. Seriously? Why? How do you pass time? This is the curse of Netflix. It's ruining our youth. All right. No, I'm just kidding. If you see any of our patients who are like overdosed on drugs or have taking drugs and all of that, you'll notice they breathe very slowly. All right. But if you and I try and hold our breath, okay, it's not actually that easy. You know, you start feeling weird after a few seconds already. Now here you've got a patient who's already, their heart is beating at like a mile a minute. You know, it's like being on the treadmill at gym and somebody suddenly asks you to stop breathing. It's not fun. It's not easy. So as much as they were saying, get the patient to hold their breath for 15 seconds, most of our patients actually won't. So what they need is they need a countdown. You just count with them so that they know there's only that much time left to go. And once you let them know that that much time is left, it's much more easier to let them comply. Okay, so I was just joking about drugs. But if anybody needs any, just let me. No, it's not ketamine and pethidine, morphine. But it really does work. I don't think we did one this year, though, because most of our patients were unstable. The last one I can remember was quite some time ago. But those who are stable, it really does work. We have done it for them, and it really does. Right? So that's one of the things that you can use. All right. So how many of you have defibbed a patient? Besides Dr. Moores, has done so many now, she can just do it without the machine. She's so full of electricity. Any of you guys have a defibbed a patient? Okay. But you've seen it on TV, isn't it? The whole rub it together, clear. Okay, there's a completely wrong way to do it, by the way. But in any case, at least you know what a defibrillation is, all right? So what is a synchronized defibrillation? A synchronized defibrillation is basically us synchronizing the defibrillation to the particular beat of the heart, all right? So in other words, we're trying to catch the heart as its maximum contraction, okay, when it's beating this fast. It's kind of like hitting your phone just as it powers on, if you get what I mean. You're going to break it just as it switches on, in the hope that when you switch it on the next time, it will switch on properly, if you get what I mean. All right. I know it sounds a bit weird, but that's the only analogy I can think of that kind of works. So that's what we're doing at the moment. So you can see these little white dots over here. These are actually when the machine is picking up the R wave, or when the ventricle is at its maximum concentration, at its maximum contraction. And it's telling us that's where we need to shock. Now, you and I can't follow this. It's too fast, right? Our human, agility and reflexes are not fast enough. So the machine actually times the defibrillation for you. That's the only difference. When it's not synchronized, you just decide and you press. When it's synchronized, you press, and the machine might wait like a little second before it actually delivers the charge. That's the only thing, all right? So what it does, it catches the heart at its maximum concentration, maximum contraction, and then poof, just stops it completely in the hope that it will start again, okay, and go back into sinus rhythm. So we're just going to see that for a second, right?
Cardioversion, you deliver a shock synchronized to the R wave of the ECG being monitored in wave sector 1. You can monitor and perform synchronized cardioversion through the multifunction electrode pads or external paddles. Or you may choose to monitor the ECG through monitoring electrodes connected to a 3, 5, or 10 lead ECG cable with the energy delivered through the pads or paddles. In this case, we'll assume we have prepared for both monitoring and synchronized cardioversion using the multifunction electrode pads and have a clear signal and large QRS complex. With the therapy knob in the monitor position, press the sync button to activate the sync function. This message appears. Confirm that the sync marker appears with each R wave. Turn the therapy knob to the desired energy level setting. Press the charge button on the MRX. Make sure no one is touching the patient or anything connected to the patient. Press and hold the shock button on the MRX. A shock delivers on the next detected R wave. You can deliver additional synchronized shocks simply by pressing the charge and shock buttons again.
Okay, so after they deliver the shock, it goes
Disabling the
back
sync
into
function is as
sinus.
easy as pressing the sync button.
He just kind of repeats himself for a second over there. It's also nice and calm, but when we're doing it, we're running around, screaming at one another, switch this off, stand back. So anyway, but at least you know what it looks like now. So it's fine. All right, so that's the end of that. Okay, that's just a joke to finish off. So the thing is, like I said, I just wanted to get everybody back in the groove. Those of you who have been with us, those of you who are new to us, we will basically follow this format like every time we do ECG. All right, we look at the ECGs from a very critical point of view. All right, so well, not just you guys sitting over here, but even the guys on Zoom. I think maybe tomorrow, maybe Monday, or yeah, well, definitely tomorrow. We'll try and do some of the ECG basics. It doesn't take very long to learn. It takes like about 30 minutes per basic, all right? And you just get the idea of how this ECG works and how it functions. So we'll try and do it over about 2 or 3 days, so that maybe even next week we'll do another ECG just to reinforce what we learned, and so that you guys can understand. Because those of them who've been with us since last year, we've actually gone quite far. We analyze quite weird ECGs now, but I know most people haven't had practice since the beginning of November. But any questions, anything you want to know, anything that's like troubling you out, weirded you out, are you worried? Next time you put an ECG on a patient, like, oh God, I can't see anything, kill all of them. No, don't worry. That's why Dr. Moses, Dr. Kemraj, and myself are here, right? Okay, and the guys on Zoom, same issue. If you guys were lost at any point, then we'll have those sessions tomorrow and Monday, maybe. It'll take an hour, so we'll just finish that up, all right? Okay, then if there's no questions, I want to go home and sleep. And I'll post this on the group a little bit later. And if you guys have any questions, you're more than welcome to, message me and things like that. So next week when we do ECGs on Thursday, there's not going to be any hand holding and quietly taking you guys through. I expect you guys to at least know the basics, which I'll cover tomorrow and Monday, all right? Now, that doesn't mean I expect you to know the answer next week, Thursday, but at least I expect you to give a critical analysis to say, okay, I understand more or less what's going on, even if I can't get to an answer. I know this is normal or that is abnormal, which is all that you really need to know, whether you're a student or an intern, or even at a ComServe level at some point. You just need to know, listen, this is abnormal, because it means you can ask for help. There are many times I see ECGs as well. I'm also not sure. I ask for help. Okay, there are many times cardiologists stand in corridors and argue with one another because they're not sure what exactly the interpretation is. So none of us are meant to be perfect, but at least we should know normal from abnormal. Okay, all right, cool. So I will see you guys tomorrow then. Okay, we'll end it now for the Zoom, guys. Thank you, bye. And so I will